Now, to frontal plane. Abduction and adduction. And this is where, sadly, we get to where, just like how the ankles have their own weird terms, dorsiflexion, plantar flexion, dorsiflexion, we're going to have areas of the body that, although they're all frontal plane movements, and you'd be justified in talking about abduction, adduction, thinking like that, they're going to have their own terms because they just want to mess with you. So, got to play the game, and it's what it is. Same thing when we get to some rotation, okay? So frontal plane, real easy when you're talking about the ball and socket joints, and because it's just jumping jack. A B-duction, out and away, add back to the body. And it just can turn into gobbledygook, either somebody saying it, or if you hear the abs and ads. So A-B-duction, A-D-duction. Is how I try to say it, just so it is easier to understand as I'm pronouncing it. So, AB. Now the hips don't need as much mobility, they have more stability. So 45 is pretty good, right? You may see some people that, wow, but 45 is all we really need. The shoulders, you do need more. The shoulders, the ideal range is 90. But even at just 45, if I can make up the difference with my scapula, I functionally at least could reach something at eye level. So you could get by with 45 degrees, but yeah, that wouldn't be ideal. 90 here, 45 here. If we go to the rest of the body, now they start getting named differently. So that's the sad part. For the ankles, this is going to be part of everybody. Go ahead. Assess your own bodies and keep you engaged. All of these movements can be essential relative to assessment. We can break these movements down, but they all get coupled into, as I said, some kind of element of your classic movement-based therapies. So with the ankles, the action would be this. If we just lift, we're going to stand predominantly on one leg, and we're going to talk about two things together. One leg we're standing on, and that was perfect. Which way do we tend to tip if we're standing on one leg? Do you see most people do this? Or do they do this? Side to side. What does a trapeze artist have to have? Not an anchor that they have a pendulum forward and behind them, right? They have a pendulum on either side to give them more stability, side to side. In frontal plane, related to abduction, adduction. Aha. So they're your balance muscles. If a trapeze artist needs it, we need it too. Okay? So one leg might seem like it's just staying nice and stable and perfect, right? But what the ankle has to do is inversion, inversion, or eversion. And you're going to have a bit more inversion than you're going to have eversion. But if you don't have enough in either direction, that's going to affect all kinds of stuff. If those muscles get too tight, they'll start limiting sagittal plane movement. And at the very least, they'll start also affecting just your basic balance. Okay? So this is just assessing inversion, eversion. Can I clear my arch? Can I clear the other side of my foot? And turn that over. Right? And then compare one side to the other. Now that's not an action we really do functionally too much. Just seeing which one's easier. Another way to, well, we'll talk about the balance part first. But if you just stand on one leg versus the other, one is going to be easier than the other. And if you're too good at this, close your eyes, and that'll screw you up. So, yeah. Yeah. A little bit worse on my right. But I practice this stuff because I want to be able to show off in a situation like this. So, single leg stability. I mean, really actually very important. There was a cool metric that came out not too long ago about people being able to have at least 10 seconds. That doesn't have to be on the first try, right? You get better at it. 10 seconds of single leg stability on both feet projects that you will continue to survive If you lose that single leg stability, it's a metric that usually shows that we're in decline. So, balance. Now what's happening at the ankle though is either this, or it could be at the hip, where it's this. Both frontal plane. But it's inversion, eversion. The muscles that accomplish that, they're helping keep the ankle stable. Then, if that's good, but if it's not good, you're gonna see this. You're gonna see a wobbly leg back and forth, right? That's what you would see. And or feel. And when you identify that, then you know that's what you need to work on. Cool. Now, a cool way that I have used to interface with this in the event that something is off is if you take the leg into hyperextension, a little bit of tension on the Achilles, and then you can do a couple of things here. If it's toe stuff, this is not frontal plane, this would be sagittal plane. But if you put the Achilles on tension, you can do that a couple ways. Usually I have to drop, and I just enough to feel like the Achilles is a little bit stretched, not going into an aggressive, full range. Now try taking your toes into extension and flexion. And then compare that on the other side. It's a way to stabilize one structure and then mobilize the structures that are directly underneath it or antagonistic to it. Now, you can do the same thing with that by taking the ankle and then playing with inversion, eversion. And seeing if one of those feels like it has more of a hang up relative to the Achilles. And if you haven't had a thing with your ankles, then this is good, that it shouldn't feel like it's weird or asymmetrical. I had a small Achilles tear, not bad by any means, I didn't need any surgery or anything, but it feels a lot more here when I try to go into inversion as opposed to eversion. I can feel that when I take my ankle into inversion, it puts more strain on my Achilles thing. So I know it can be important to affect my inverters to help my Achilles symptoms. But for function, you need that for, now where do they live is the weird part. Tibialis anterior and tibialis posterior, they're your key inverters. So it's a little bit odd here in being able to like give you a statement of, well, they do inversion, they should be on the medial side of the body. There's nothing over there. It's just a tibia, right? So these muscles have to, based on how they're designed and where they attach at the ankle, they come over and they attach more medially. They actually accomplish that inversion action. The everters are easy. They are actually on the outside of the body where physically it makes a bit more sense, right? The muscles that would pull and do that, yep, they're right there. But the muscles that do that, wait, there's a bone there. And it's not gastrocnemius that does that. That's about knee and plantar flexion. So, tibialis anterior posterior. Why it's important to think about this deep unit and this anterior and lateral unit, because here we have something that's involved with lots of stuff. On some level, this whole continuum is about toe extension, dorsiflexion, inversion. We go lateral, eversion, behind here, knee flexion, plantar flexion, underneath of it, toe flexion, and inversion. Again, right? Just being thorough is what's essential here. So the shortcut to doing good work here for people that, even if the symptoms are higher up, is just working on this stuff in multiple positions. Because as we've seen ergonomically, it's hard to get to some of this stuff just in prone and supine. All right. Here it gets a little bit easier at the hip and as we go up. The adductors of the hip are there. Let me try to so you can see. Not too bad. Stuff that would pull the hip this way, not too bad. Now where would the adductors be? What's cool is that the whole group of muscles, just like these are named the quadriceps, these are named the hamstrings as a group, but you have to learn their individual actual names, like bicep femoris and semitendinosus, semimembranosus.
Are we tested on that?
Yes. Very much. You got 100%, I promise you, even if I think it's actually long term, not the most important thing. I think you should know more about functional groups and the actions of muscles rather than having to worry so much about memorizing every single muscle and all its innervations and all that stuff. I think practically long term, that's what really matters. But to pass the test, you gotta memorize all of them. You gotta do it. That's why I get the flashcards, get the app on your phone. If you haven't done it, do it now. You gotta memorize every single one of these stupid things. Gotta do it. All right? All right. Adductors, that's the group of the muscle, that's the big group name for these inner thigh muscles. Guess what they do? Adduction. So on one side of the hip, other side of the hip. Kind of above and a below kind of dynamic, but makes sense from how you visualize it. Abduction, abduction, abductors. Return to that, adduction, adductors. But what we have to remember is just like how the ankle has to facilitate inversion, eversion to keep us from toppling, so does the hip. So as I walk, there's a lot of subtle interactions that you're just not aware of happening with your abductors and your adductors as I'm doing this stuff. We think it's all about flexion and extension, and it is not. Like as I move my leg, as I bring my leg forward, what's actually happening? It's a little bit of a, what's that? I'm doing adduction. I'm not rotating my hip, I'm not doing this, right? Not using our rotators to accomplish a lot of these actions. We're using flexion plus adduction, or we're using abduction, flexion, adduction. So adductors, abductors, essential for the flexors and extensors to be able to accomplish this stuff relative to a bigger full body motion. So somebody's having gait issues and they're having symptoms in their knees and their hips, right? They may feel it more here, 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 whatever. The adductors do not get addressed because people are scared of inner thigh, ugh, right? But these are huge muscles that are involved with stabilizing the hip, and they cross all the way down on the medial side of your knee. So even like medial knee issues can be a big part of adductors, being too short and tight. So that tends to be the pattern though. These will get weak, these will get too strong, and then people are stuck in kind of more of a shuffly stance because they can't get the swing action. And that leg swing action is predominantly about abduction and adduction coupled with extension and flexion. So, all right, jumping jacks. That's where this can all get easy. So if we're assessing it or we're doing a movement-based system that's good for us, we can look at, well, can you just go side to side? Can I at least just go from feet more or less close together to side, we used to do kind of a walk the world thing, where it would be step forward, step on an angle, toes forward, I'm not rotating, toes forward, on an angle, side, to side, on an angle, behind. So that breaks down the actions you would need for a good gait into an easily digestible routine, right? Okay, so hip stuff will come down to a big, like all of it together. Now, when you get to the spine, it gets turned into lateral flexion. It's not abduction, it's not adduction, it's lateral flexion. So, hips stable. If you have them have their arms either against their body or kind of stabilized like this, something I can watch is how far does a wrist go. And I can use that as a point and line of reference a bit, because clothing can sometimes get in your way. So if you just watch my hands, I can give you a metric. If I slide the hands, that's another good one, of go to your side but slide your hands down. And I, as the therapist, can watch what their torso does, but I can look and identify with maybe an easier initial measurement how far their hand gets down the side of their leg. You should be able to at least get to your knee, the side of your knee. Get the mosquito. And that's combined actions. Is you look at the hip, will hike out to do all this. So it's not perfect. This would be true, and just letting people cheat because they'll drift. These combined actions will occur. And what's happening when a person does this? Can we guess what the movement we called at the hip when I do this? Abduction and adduction. Isn't that cool? Look at this. That's just like this. Look at this. That's just like this. So this action actually, so people do like the rotations and all that kind of stuff, but if I'm just using standing and gravity and posture as a factor here, I can do this stuff in the sagittal plane for lumbar related movement, but it's also affecting the pelvis and the hips as we do this, and then I can do the side to side action, and that's going to affect the adductors to the hip. And I could use that of even seeing how much a person can go from one side to the other. Usually from a practical standpoint, you're just trying to watch what a person tends to stand on more. If they really hitch their hip over dominantly on one side, then what's long, what's short? This is long, this is short. Voila. Lateral flexion, covered that one. The spine, the cervical spine, thoracic spine, guess what? It doesn't do any of that. It's in a cage. So the movements of the thoracic spine are going to be about your ribs. And they're not supposed to have a lot. That's why it's problematic of like kyphosis and stuff, because it disrupts how things are oriented to the lumbar spine. You get too kyphotic, that's going to change how your body weight is being distributed here. It has to change what your neck has to do in order to keep your eyes level. So, anyway. The neck. We did flexion, extension, hyperextension, but then lateral flexions. I sense one side's different than the other. So that's a pretty easy one, right? To identify the neck. And with this, we're going to couple elevation, depression of the shoulders, as well as with the abduction, adduction. So from an assessment standpoint, I tend to think that it's easier to couple the elevation, depression of the shoulders relative to frontal plane stuff. So what you'll tend to see, everybody was really good about this last week of identifying which shoulder's too high, right? Okay, but what's the neck up to then? If I were to take the shoulder down and let the neck go with it, so you have a kind of coupled scapula is elevated, cervical spine is going to be pulled into lateral flexion to the right side. So that's why there's always going to be some kind of unification here with the scapulas to the neck. So elevation, yeah, depression, elevation, and depression versus abduction. Once we're past that and the scapulas are moving, it's going to be called upward rotation. And scapulas have to do this kind of swing so that the whole ball and socket joint is being moved out. So it starts with abduction of the shoulder joint, the glenohumeral joint, then it turns into upward rotation of the scapula to get to the rest of that. And then we're doing downward rotation of the scapula, and then we're doing adduction, adduction of the shoulder joint. Right? With the scapulas, you also have protraction, retraction. So here, how much can I further reach? So we start with just flexion of the glenohumeral joint to 90 degrees, and then we see how much further can we go. And people can kind of trick you with it. Not that, so. And then back. Should feel like you're pinching those shoulder blades together, right? So this is what push-ups ultimately end up being about at the end range. It starts with, like with a push-up, this is actually what's called horizontal adduction. This is adduction, This is adduction. The arms are like this, and I seal clap. They call it horizontal adduction. But if you watch what happens in a push-up, watch just the humerus. Horizontal adduction. And if I go further, protraction. Okay? You've heard it. The scapular movements will have to come back around too, because that's a lot. Same thing with like pelvic tilt stuff. When we're trying to throw all this all at you, it's already turning into, I'm sure, word vomit. No. Word salad. Make it more palatable. Word salad. Okay, so scapular stuff, neck stuff, not so bad, right? One little extra thing with neck stuff that I showed you, and it's mostly just because of my personal journey that I make sure I hone in on this, is thinking about this action too. I do this to kind of just, it's just me stabilizing, making sure I'm not, but try to be a, you know, what, a ferret, a snake, something. The birds are silent. The birds do that. So, not a dove. I'm trying to be a snake coming out of the basket.
I follow a chiropractor, he calls it the Janet Jackson.
I like, okay, I like that, the Janet Jackson. Yeah, that's great. So that is a frontal plane movement. And it is different than just lateral flexion, right? So just two things to consider as you're doing assessments with people, because that can help you hone in on what's going on with the neck. Is it this or is it this? All of it. The benefit is going to be you have to kind of learn all these pieces, but it's going to always come back around to generally work on all of this in at least a couple different positions. That will take you to where you need to go. And then you get to, with palpation assessment, feel where it has extra tone, and through all this, be looking for the caves, and then post-assessment, seeing if you're helping a person return to either more free and efficient motion, or the symptoms are reduced, right? That's your trial and error. Generalized, cool thing. First sessions, generalized full body, lot more assessment, and then as you hone in on these things, you can get more precise in the things that you actually need to shorten or lengthen. We're going to do better at lengthening stuff that's too short, identifying caves. Okay, to rotation. Whoops, sorry. Frontal plane stuff, where those things are located. No, this works. Once we're talking about the shoulder joint, there's only one thing here, right on the appendages, a couple of things that are involved with the abduction element, and they're going to be right here on the top. So it kind of makes sense, right? They'd be involved with pulling stuff up. Deep is that's part of the rotator cuff, that's supraspinatus, but then the big one be deltoid. So I'm mostly honing in on deltoid. I want you got your biceps and triceps figured out, I'm sure, but deltoid. And deltoid does a lot of cool stuff because it has fibers that are anterior, posterior, and lateral. So the fibers of deltoid, we learn it as one muscle, but deltoid is involved with shoulder flexion, shoulder extension and hyperextension, and abduction. When we go into flexion, those anterior fibers shorten, posterior fibers need to lengthen. So it can be an antagonist to itself in flexion and extension. In lateral action, this one, it's supposed to be kind of the workhorse. So deltoid has kind of how many parts? 3, okay. Now coming to the ball and socket joint of the hip, you hear the glutes, plural, right? There's gluteus maximus, but then there's also gluteus medius and minimus. So 3 glutes, 3 deltoids. I'm going somewhere with this. What muscles do you think are paired with each other relative to the hip and the shoulder? The hips and the glutes and deltoid. And even gluteus maximus and deltoid. Look, they're awfully similar in their overall shape and design, right? So one group, 3 muscles, kind of cups the ball and socket joint here. This one sits right over top of it, kind of like an epaulette kind of a thing. So I say that just because people will tend to think the pecs, which are on the front, and gluteus maximus, for example, that's on the back, that's a paired relationship because From an anterior posterior standpoint, you'll think, well, biceps to hamstrings, you know, like you'll be more that front and back kind of a deal. All right, deltoids to glutes. Your pecs, pectoralis major, and latissimus dorsi. These things are these big triangular shaped muscles on angles. Sandy drew a thing on the board that was like shapes that are either like a tube that goes up and down, tubes that go side to side, or triangles. They're shaped like triangles, they tend to be adductors or abductors. So here, upper trapezius and deltoid, they're involved with abduction when they shorten. The other muscles, latissimus dorsi and pectoralis major, they are the adductors, okay? So if somebody comes in and they can't get their arm to 90 degrees, what's short, what's long? And they go, it hurts here. It hurts here. Well, show me, let's go through the shoulder motions. Which one's limited? They go, hurts here. What's long, what's short? Long, short. Okay? Big factor with shoulder stuff. That's your go-to, is it's pecs and lats. Free those up. Now see what can happen. Don't have to worry about mashing around here as much. Upper trapezius, one of the big reasons to go after it is because it can be short relative to this scapular elevation. So it's kind of just a weird thing where it'd be short here because of the scapulas, but then things get out of sorts and it is what it is. But a pattern here tends to be upper traps, lats, pecs. That'll take you pretty far relative to most shoulder stuff to start, right? Okay. We talked inversion, eversion at the ankle. Here's at the wrist. So it gets named for the bones it's moving towards. It sounds kind of counterintuitive to me when they say deviation. It doesn't sound like it should mean going closer to, but that means it's what it means. So a deduction of the wrist is actually going to be called ulnar deviation. Okay? Going closer to the ulna. A abduction of the wrist would be radial deviation. So radius, if I think my right hand, my radius is on the right side in anatomical position. So ulnar deviation, radial deviation. That's just, you have to learn that one just like inversion, eversion. Inversion, eversion makes way more sense. I would like it to be that, and I think there might be synonyms and stuff out there, but you're going to tend to see ulnar deviation, radial deviation be the more common one, okay?